I'm Dr. Jam Katari.
And I'm Dr. Sally Moore. And this is a Myeloma Minutes, a podcast for people affected by myeloma, patients, friends and family.
Good evening, Sally. Good to see you again.
Lovely to see you too. It's late in the evening once more, but here we are to talk to our listeners about the next phase of the transplant journey. But what's been going on with you? How's things?
Yeah, fine, thank you. It's a bit busy time. I'm covering the ward again at the moment. Lots of different types of cases, myeloma, lymphoma and lots of other things. But thank you. Yeah, all going well. A busy time, but I'm really excited to continue the arc of the story where we left off. We just talked about the transplant, that the transplant had been completed and our patients going home. Really, what happens next? What happens after the transplant is done and as people are recovering? Where does the treatment story go?
I think the first two pods we covered a lot, but unfortunately, or fortunately, there's still more to talk about. So what we're going to explore today is not just that recovery period, but when your team might be thinking about giving you more treatment and what that treatment might look like. So just as a quick recap, we discussed in the previous podcast the treatment you have before a transplant to control the myeloma, the role of the transplant to further deepen that response, and then what that transplant looks at like in terms of recovery whilst you're an inpatient. But we also referred during the last episode to recovery at home. And I guess this is where we're going to pick up today in terms of when you have recovered at home, what comes next? And I guess I can kick off that jam by saying, once you're discharged from hospital, you'll be seen pretty regularly in clinic to make sure that your blood tests are back where that you need them to be and that you're feeling rather better. And hopefully, as we discussed previously, the people who've gone through a transplant will get stronger and stronger week by week. And then as they do so, as they get stronger and their body recovers, we will begin the discussions about the next line of treatment with them.
The modern way of continuing the treatment is with what it was called consolidation chemotherapy. And typically that's 2 cycles of what was given before the transplant. So if our listeners remember, you're given 16 weeks normally before the transplant, and that's 4-week cycles. And then after the transplant, we give 2 of the same cycles, but only a total of 2. So it's 8 weeks. Now, exactly when that starts is, I have to say, different in different places, and it also partly depends on how well you recover from the transplant. But broadly speaking, you may start that somewhere around 40 to 50 days after the transplant, ideally when your blood counts have fully recovered. And some of the doses of the drugs may be reduced because of maybe problems or side effects people have had either from the initial treatment or from the transplant. But that period lasts 8 weeks. And then after that, we get into what is called maintenance treatment. What is maintenance and where really was the idea born and why do we do it?
So much to unpick there, isn't there? I mean, I think it's safe to say that by the time you've come out of the transplant and you're getting your life back in order, hopefully most people are over the worst. You know what's coming in terms of that consolidation. As you said, the doses can be modified and then things get hopefully easier even further with maintenance. And people are on maintenance treatments for many, many years, hopefully, to help control their myeloma. And therefore, because that treatment continues for a significant period of time, it's really important that people have a good quality of life during that period. But maintenance is basically, as it says on the tin, the idea is that you've achieved these hopefully nice deep responses with your treatment and your transplant so far, and you want to keep on top of it. You want to keep a lid on the disease, and that's what maintenance does. It maintains your response to hopefully enable your body otherwise to get back to normal, your life to return to normal, and keep the myeloma away for as long as possible.
The reason why maintenance has developed is that keeping myeloma in remission historically, unfortunately, was very difficult. And understandably, people looking after the condition thought, is there an approach that we can do to stop the myeloma becoming more active, potentially sort of mutating, genetically becoming more aggressive? So for decades, people have looked at different sorts of drugs that could be used as maintenance. Back in the 60s and 70s, steroids were used as maintenance and not very successfully because they were poorly tolerated for the reasons that we have talked about at length. And as newer drugs have been developed, different drugs were looked at. Drugs such as something called interferon, older drugs such as thalidomide. But the story really started to develop when this drug lenalidomide was first looked at maintenance. And now this drug lenalidomide is essentially the drug that the majority of people at the moment, certainly in the UK, are getting as you say, this treatment to try and keep the myeloma under control for as long as possible. So the hard lifting has been done by the induction, the transplant, the consolidation, and the maintenance is there hopefully to keep the myeloma under control. In some circumstances, actually improve what we call the depth of remission as well. So maintenance can get rid of small amounts of myeloma and push the myeloma to an even sort of better level of remission. And as you say, Sally, as people stay on this drug potentially for a number of years, quality of life and ensuring that people can tolerate the drug is really, really important.
And something else that's, I guess, important to say about lenalidomide in particular is it works through, one of the ways in which it works anyway, is it sort of wakes up the body's natural immune system to notice any residual myeloma that might be left behind. So it's a rather clever drug in that regard. And we've spoken about that and how it works on previous podcasts. But we also mentioned previously that some patients may have had this during their initial treatment. That's not yet standard in the UK, but that might be coming soon. But our listeners in other parts of the world may have had lenalidomide to begin with as part of their induction. And the dose for the maintenance approach is lower. It's different. You don't have the steroids. You don't have the other drugs. You just have a lower dose of maintenance by and large to control the disease for as long as possible.
And in an ideal world, the perfect maintenance drug is almost a drug that you should forget about. We know that for many of our patients on this agent, that isn't the case. But, you know, if you were to develop an ideal maintenance drug, it would be something that you took every day and you'd forgotten that you'd taken it, and it had minimal side effects, and they are side effects that you feel day to day, and also the side effects that sometimes it can have on your blood counts, and also minimal long-term risks as well. So that is an ideal maintenance drug. And I think an important thing to say as well is that if possible, you shouldn't have to take it indefinitely. Now, the way that lenalidomide maintenance has been developed, and a number of the trials have been done, is that actually it is given until progression. And this can be a number of years. And understandably, people are there going, what? Like, I've just had 4 drugs for weeks, and then you put me to this transplant, and then I've had consolidation, and now endless lenalidomide. And it's a lot to get one's head round. We know from many years of data that for many patients, this is an agent that really has improved what we call overall survival. So people live longer if they have lenalidomide maintenance. And for many people, it is well tolerated, but we will certainly delve into the side effects of maintenance and what you have to do for some people who are struggling with the side effects. So Sally, if we just think of someone who's completing consolidation, historically before consolidation, around 100 days after the transplant, the myeloma would be reassessed with a bone marrow and a scan. Now, we typically actually do this after consolidation now in Oxford. Is that similar to your practice before starting maintenance?
I think we're slightly different where I work. And I think our approach is perhaps one of, what can I say? Is it pragmatism, perhaps? I guess because our treatment pathway in the UK is so clearly defined that doing that day 100 bone marrow is important and is interesting in terms of hopefully confirming in near enough everybody that the myeloma is better controlled than it was. But it's not necessarily going to change your treatment pathway. So actually, we don't do that necessarily consistently in Bristol because people are going to continue onto the maintenance pathway anyway. Now, you could argue for and against that approach, but we've spoken before about bone marrows are not the most pleasant examination. And if a patient was very keen to have a bone marrow done with us, we would certainly offer that or do that for them. As a part of our standard pathway, it's not quite embedded. When the time comes when we can change our approach according to that bone marrow results, we will no doubt insist on it happening in everybody.
Slightly different approaches in different parts of the country, and I think, but when lenalidomide maintenance starts, Sally, as you say, the dose is slightly lower. So can you just go through how it's given and what the support medications are with the maintenance.
Yeah, so for those people who've already had lenalidomide, they would have already had a go around the block, so to speak, in terms of appreciating its potential toxicity. But the standard dose when you're giving it to treat active myeloma in someone who's otherwise got good blood counts, good kidney function, and can cope with the highest dose is 25 milligrams for 3 weeks out of every 4. So 3 weeks of taking the tablet once a day and then a week off. In maintenance, it's 10 milligrams. So more than half of the dose is removed. And again, you have that for 3 weeks out of every 4. But lenalidomide comes with other potential side effects. There's still the risk associated with harm to unborn babies and a fetal exposure that goes hand in hand with it being related to thalidomide. So that risk continues for the duration of the maintenance therapy. It can also come with a risk of blood clots, and that's particularly important if somebody has had a blood clot before, so somebody might be on blood thinners. And there's a risk of bile salt malabsorption, which I think we've spoken about before, so diarrhoea and skin rash and so on and so forth. And then alongside all of that, people are on treatment, as I said, blood thinners potentially antivirals, particularly if they've been exposed to Velcade or bortezomib before. They may or may not want to continue with anti-indigestion tablets if that's a problem for them, regardless of not having steroids. And they may on be some other antibacterials, for example, or other supportive medication for their immune system if they've had problems with infection before. But in reality, Jam, I'm sure you'll agree, this is where you can really actually whittle away at the drugs. You can cross an awful lot off, because this should be actually a very refined part of the pathway, where in some cases the patient may only be taking 1 or 2 or 3 drugs in total in terms of managing their myeloma and the side effects of the medication.
And for people that have had lenalidomide before, in a way, you know a little bit about what to expect. And certainly what a lot of people have seen is that the rash, for example, isn't an issue if you've had lenalidomide before, because almost your body is used to it. But in the UK, if you've never had lenalidomide before because you've been exposed to thalidomide as part of your initial pathway, that is something that maybe you might see a little bit more often, but it's usually transient and manageable, and people can get back on the drug quickly. All the other side effects are really important. This is where you get into side effects and how long one is willing to sort of put up with something, because people whose myeloma is under control and genetically stable can stay on lenalidomide maintenance for years, 3 years, 5 years, longer even. And if you have, say, a little bit of diarrhea, for example, that is caused by this drug, if you know you're having it for 16 weeks, it's almost like, I can deal with this because I understand that it's related to this drug. I need to be around a toilet at certain times of day, but I will accept this because it's for a short period of time. It's an important drug for my cancer, and then I can move on. Okay. But if you're on lenalidomide maintenance for years, the aim is really that the maintenance should be in the background and you're doing whatever you need to do in your life, not thinking about where the next toilet is. And that's why I think thinking about toxicity in maintenance is actually different to thinking about toxicity in certain other environments in myeloma. And something that we'll also come onto as well is that for the first number of months and during the transplant, you will have seen lots of consultants and registrars and other doctors. But when you are on this part of the pathway, it may be that you see doctors less as well, and more appointments may be by telephone, just because of the nature of how maintenance works. But it's really important that every day you log the side effects that you're getting. I think in a way, if you can, measure your quality of life as a score and really look at that week to week, because our job on maintenance is to absolutely keep you in remission, but also modify where needed to try and minimize side effects and optimize quality of life.
Yeah, definitely. I mean, this is almost like you're in it for the long haul, isn't it? And actually saying that, this is the time where you can go on holiday. You are free to some extent in that you're not so tied to the hospital in terms of appointments and follow-ups. You could, have the confidence, hopefully, that your myeloma is going to be in remission for many years, if you said, Jam. So therefore, anything which is kind of niggling at you and making you feel less well than you'd like to feel is always worth talking about. And I'm glad you mentioned that, because I think the diarrhea in particular, some people think, I can just stick up with it. And I would say to our listeners, if that is something you've experienced, just have a chat with your team about it, see what they can offer, because it can often be easily remedied. And it's just nice to feel a little bit perhaps freer We love hearing about the holidays our patients go on, Jan, don't we? It's kind of like we ask them to pause and pause and pause their life, like, right, now crack on, and don't quite send a postcard because it makes us envious, but have a great time.
Other things, cramps, they can be quite insidious with lenalidomide, and again, just really impact quality of life in lots and lots of ways. And there's a number of interventions that can be used to minimize cramps. As you said, Sally, we have good interventions for minimizing diarrhea, and it doesn't work for everybody, but there are a number of tools that we can use to try and minimize the impact and keep people on maintenance, because still at the moment the standard of care is to continue lenalidomide maintenance for as long as is possible. Sally, when do we need to consider reducing the dose of lenalidomide? That does happen relatively often.
Yeah, it does. I mean, lenalidomide is what we call sort of excreted through the kidneys, meaning that if your kidneys aren't working at full speed, perhaps because of the myeloma, perhaps because of other health problems like diabetes or whatever it might be, high blood pressure, for example, your dose of lenalidomide anyway, before you even start the maintenance, is likely to have been lower. And therefore, when you enter that maintenance phase, it may need modifying further. So instead of having 10 milligrams for 3 weeks out of 4, you might start on 5 milligrams, and that is the right dose for you. And it's also really important to say that once a person has been through a transplant and consolidation and come out the other side, their blood counts might be maybe a little less sort of robust than they were previously. And those patients may also need a slightly lower dose to make sure that we don't push their body too hard. Because if you have too big a dose of lenalidomide, your blood counts, in particular those cells that prevent infection, for example, could be too low and therefore increase your vulnerability to things like infection, which is not what we want at this period or part of the journey.
So if blood counts are struggling, sometimes we'll need to reduce the dose. As you say, in different levels of kidney function, we need to reduce the dose. And for some side effects as well, sometimes we need to reduce the dose as well. And of course, our patients also have other health problems as well. And sometimes it can be very difficult to know what aspect of their health is impacted by being on maintenance treatment versus other things that are happening. A drug holiday is often a good idea. You can sometimes say, you know what, we're just going to stop everything for 4 weeks and let's see what changes. And that can give you clues of how much maybe the maintenance is contributing to the side effects. And as a general rule, if you don't have the drugs for a month, it's not going to make a big difference to the vast majority of people. And Sally, as you know from some of the very big series of patients that have had lenalidomide maintenance, the UK has been one of the sort of the leaders in these sorts of trials for lenalidomide. We know that about 40% of people actually have to stop it because of side effects that they get or side effects on their blood. Even in that situation, people are having prolonged remissions.
They've already achieved a lot, and there's a gain from the lenalidomide they may have already been exposed to. So even if you do have to stop, it's not necessarily the end of the world, and hopefully your remission will be prolonged thereafter because of that treatment you've already had. I guess it's also important to say, whilst we do consistently encourage people to continue with this treatment, because that is what our studies have shown us, the studies have also shown that maybe if you're in a nice deep remission and you've been on maintenance for 4 or 5 years, it may or may not be so crucial to persevere with it regardless. So keep that conversation live. Know that this is not, and we've said this before about myeloma, an exact science. The standard practice is certainly to continue with it if you can, but if for whatever reason you have to come off it, please don't be heartbroken. Celebrate that all you've achieved and continue to be followed up by your team.
Right, Sal. So in an ideal world, we've talked about lenalidomide, which in the UK is what we can give as a standard of care. But in an ideal world, would you give lenalidomide or might you combine it with something else?
So, yeah, and I think if we were to record this podcast this time next year, we'll be talking about different types of maintenance, to be completely frank with you, all being well. Because there have been some brilliant studies conducted over the last few years which have looked at improving this remission period even more. And they've explored it, again, hopefully using drugs which are pretty well tolerated, so your quality of life isn't necessarily impacted on, but nonetheless are still very effective at controlling the myeloma. And it looks like one of the anti-CD38 antibodies, a class of drugs called daratumumab or isatuximab, there's a whole family of them, in addition to lenalidomide, for example, tend to eke out the remission period for even longer. And that can extend into many, many years. And so it may be that, like I say, this time next year, we're able to offer more than one drug as part of the maintenance. Should that be the case, we'll be doing that because the evidence suggests that will control the myeloma for even longer. So exciting times ahead. I suspect that's already happening in some parts of the world, not yet in the UK, but I wonder if that's going to be the new frontier. I suspect you agree, Jan, that's perhaps the direction of travel.
Indeed. I mean, certainly the combination of daratumumab and lenalidomide as maintenance is an approved approach. And certainly I know in North America, I think it's a standard approach for the majority of patients. And for certain types of patients in the UK, private patients, that is also available. And in that approach, 2 drugs are continued for at least a couple of years. And then if certain criteria are met, you actually stop the daratumumab and continue the lenalidomide. Sally, I often get asked, surely continuing a drug for like years and years and years must have some long-term side effects. So things that maybe don't affect me day to day, but what is it doing to my bone marrow? Does it increase the risk of other cancers?
There is a signal, isn't there, with lenalidomide and secondary cancers. And when I speak to the patients I look after about this, I tend to say that unfortunately, by virtue of having myeloma in the first place, which means that your body has not been able to detect the cancer when it started growing and it's sort of flourished within your body, there is therefore an increased risk that you will develop another cancer later. And when you then throw in treatment to that and a transplant, that risk increases a little further, and lenalidomide also increases it further. But we do know when we're managing someone or looking after someone living with myeloma, the risk to them there and then is the myeloma. That trumps everything. But nonetheless, we do have to explain that there is this small percentage, so sort of 1, 2, 3, 4% increased risk of secondary cancers, tend to be skin cancers by and large. So protection from the sun is incredibly important. When you go on your lovely holidays, always take a hat, always cover up. But also other types of cancers are also increased to some extent, and they can include other blood cancers, for example, or other what we call solid tumours, so different types of cancers.
And that's why I think monitoring your skin is important. And as you say, Sally, being careful in the sun and making sure that you use appropriate sunblock when you are outside. What do you think about myeloma's many diseases? Are there certain groups of patients in which maintenance is more effective? And what about groups when maybe it's slightly less effective?
When we talk about responses to treatment, we tend to talk about the average progression-free survival. And I think, so what that means in day-to-day language is, if you had a certain number of people, 50% of them would progress or their disease would come back before that time and 50% would be later. But it's that person in the middle, so to speak. And we do know increasingly more about how somebody's myeloma is likely to behave. It's not black and white and it's not a given, but we can kind of crudely figure out, depending on how someone's responded to treatment so far, how deep their remission is, what we know about their underlying genetics, which side of that 50% they're going to be on. And it is still the case that unfortunately some people with what we call higher risk disease, perhaps based on their genetics or based on how their disease has behaved before, they will relapse sooner than the average. And that may be in a couple of years of maintenance, for example. And at that point, we will have to try different therapies. And those people we might choose to keep a closer eye on, because we don't want that myeloma to escape and cause more mischief without us being aware of it. So I think that's what you're referring to, Jan. And I suspect you guys have a very similar approach.
We know that there are groups of people that don't do as well with lenalidomide as a single agent. And as you say, I think it's important that they are counselled about a likely length of remission on maintenance. And this is also an area that has lots of clinical trials, and it may be that people maybe with higher risk or more genetically unstable disease may be able to enter a trial of different drugs for maintenance. And it's very much about where we can, trying to give the best bespoke solution to keep that myeloma in control for as long as possible. And that will, of course, depend on where in the world you work, how your healthcare is reimbursed, and then, of course, all the other factors in relation to the myeloma. But I think it's about having the information, getting people, through induction, transplant, consolidation, seeing where they are with their disease and taking it from there. I think we should talk a little bit about the future of maintenance. And we've touched on a couple of important points. People hate endless therapy, and I totally get it. In lots of conditions that we also look after, they are serious, but the beauty of some of these conditions is you give people 18 weeks of treatment and they're cured. And, myeloma, we're getting so much better at controlling the disease for longer, understanding toxicities of treatment better. But from the start of your first cycle of treatment or your first dose of steroids, when someone's told you you've got myeloma, to when you finish lenalidomide maintenance can be many, many years. And of course, if you continue lenalidomide maintenance until your disease progresses, well, then you have no break and you're just starting further treatment. So we have to find a way for certain groups of patients to give time-limited maintenance, and it's being actively investigated. Do you think we're going to get there soon? And how are we going to do it?
This is a source of so much debate, isn't it, for amongst ourselves and the whole community, not just in the UK, but all over the world. I think what's really important, Jam, is an understanding not just about the risk of somebody's myeloma, of the treatment working and not working, or progression and when or how that might occur, but also being able to track things as they may be changing, but not just tracking them crudely on a blood test when your paraprotein goes away and then you're just waiting for that number to pop up again, but to do it in a more sensitive manner. And I think there's been great strides made in the field of what we call minimal residual disease monitoring, which is where you're looking for any trace of the myeloma within a body. But unfortunately, at the moment, to do these specialist tests to look for these really low levels of myeloma and then track them requires a bone marrow test. And I'm optimistic in the future we'll be able to do that sensitive tracking, much more sensitive in the paraprotein or light chain, on blood tests in the future. And if we are then able to do that, and let's call that minimal residual disease monitoring on blood tests, for example, then we can look at how the myeloma is behaving. Is it going up? Is it going down? How quickly is that happening? And if it's nice and quiet and under control and has been sat there under control for a given period of time, we might be able to just pause treatment and then see what happens 6 months later, for example. And I'm hopeful, certainly within the next decade, we'll get there. It may hopefully even be before then, but it has to be a case of stopping and then starting in a way that a patient feels safe and they know they're being monitored effectively, but also it's not at the cost of a bone marrow every 10 minutes. This has got to be acceptable and not cause more suffering and more concern or anxiety. So that's what I see. If I was to cast a wish into the future, that would be my wish to happen for the people we look after. What do you think?
I'm a bit more, I think my time horizon is shorter, I'll be honest. I think it's going to happen sooner. I'm incredibly encouraged by some of the data I've seen from the States and some of our colleagues in Greece. And it really does look for people who have genetically stable myeloma. It may be that 3 years of maintenance, and I'm not suggesting that people should stop. I'm just saying this is data that is being seen and published and discussed. If you have genetically stable myeloma and you stop, lots of these people are staying in remission for a long time, but there remain many unanswered questions. It's just time off treatment is a huge thing for quality of life. It's hard to not overemphasize that point, because I think people tell it to us endlessly, but the fact that we can even have that discussion, I think, tells you how much our field has progressed, because we're actually saying, well, maybe we can stop. Now, that doesn't mean the myeloma won't become more active again, but the question is, well, when will it? And if you can just see it, can you go back on the maintenance, or should you do something different? And I agree, there's so many unanswered questions, but I do think it's our job to try and get to the answer as quickly as we can. And people are trying, for sure.
Yeah, definitely. I mean, I guess one of the skills that we also need to actively employ in clinic as well is the art of listening. And it's amazing how hard that can be, particularly if you're short on time or whatever. There's other pressures going on. Because some of our patients, I guess we've all looked after people like this, might say, actually, I don't care. I just want to stay on this, because if I stop it and the myeloma comes back, how am I going to know if it's because I stopped the treatment or not? And that's what you know so far. So keep me on it. I'll stick up with anything. Mm-hmm. Whereas other people be very much more aligned, saying, well, let's just figure it out as we go along and play it by ear. So I guess it's tailoring those approaches as well. And that, as you've said, Jam, is about having an informed discussion and figuring out what's the right approach to that person in front of you.
And if you have minimal or no side effects, it feels like taking your statin or your antihypertensive. And that discussion is very different to that person who says, I've reduced the dose, I've had this, or my blood counts have been a little bit low, I've had to go on this medication, I get these annoying cramps, I can't quite cope with this medication. And we know that lots of people don't actually tolerate it and they do have to stop. But I think it is important we use all the tools that we can to try and find that safe, effective dose, because I think it is clear that you're going to need it for a number of years. Now, what the magic number is, of course, is not known, but there are a number of active clinical trials going on at the moment using very clear sort of stopping rules, and the data will emerge. But we always want to try and be, right on the curve or ahead of the curve if we can be.
We always try to be, don't we? But without being experimental, we've got to go where the evidence lies. But yeah, it's still within somebody's gift to actually say, a patient's gift, actually enough is enough. We just have to share what we understand about the disease at that time, don't we? Which is hopefully useful for everybody. And I hope this podcast has been useful for everybody as well.
We've got to the end of maintenance. Well, not the end of maintenance, because that would be in a number of years' time, but we've got to the end of the discussion on maintenance. So can you summarize maintenance in a minute? There you go. I'll start timing.
Oh my word, countdown. Yeah, maintenance has been a super addition, I think, to what we can do to control people's myeloma for as long as possible. At the moment, it involves a tablet, which you take for 3 weeks out of every 4. Generally, the dose is 10 milligrams, but it could be less than that. And all tablets come with side effects, and this tablet is similar. It's not unique. It comes with particular problems in some people, but they can generally be well tolerated. But the aim of maintenance is to control the myeloma, whilst also enabling the people taking these tablets to have hopefully a very good quality of life. But watch this space. It may be changing soon, not just in terms of the medication, but in terms of who needs what, where and when. And so this conversation will continue to evolve. That's maintenance by and large wrapped up.
Maintenance in a minute. There you go. 54 seconds. I was timing. I was counting sheep. The treatment has sort of continued. We've done induction. We've done stem cell collection, we have done the transplant, and now we've done maintenance. So over the next few weeks, we're looking forward to hearing patient voices that will talk to us about what their life has been on this journey. So we're really excited to share these pods with you, and we'll also have one of our stem cell transplant nurses on as well. So thank you very much for your company today, Sally, and thanks to all our listeners. Do get in touch, tell us what you think. I think there'll be lots of questions about maintenance. We're always happy to answer them, and we'll be doing a few shorts on our YouTube channel as well, just to give this topic a bit more depth. Thank you very much, Sal, and we'll see you all at the next one.
Cheers, guys. Bye.
This has been the Myeloma Minutes. We hope that you found today's pod engaging, interesting, and above all, useful and understandable. Please remember that this does not constitute medical advice. Thank you so much for listening. Please do feedback on what you've enjoyed and what you'd like more of. You can email us at themyelomaminutes@gmail.com, and we'll see you at the next one. Bye.